All right, I'm going to shift gears now. We're going to talk about knees, and I'm going to first talk about two-stage exchange arthroplasty for perfected knee, and I'm going to talk about articulating spacer, and then Michael Taunton's going to talk about, I'm going to talk about articulating, he's going to talk about non-articulating spacers. By means of disclosure, both of mine are relevant. I receive royalties for both Stryker and Osteo Remedies. So similar to the hip, there are certain indications for an articulating spacer. In my hands, the indications for articulating spacer or knee are an intact extensor mechanism, a reasonable soft tissue envelope, and adequate bone stock. I didn't say good, I said adequate bone stock. I think that these definitions are evolving. Who traditionally didn't get an articulating spacer, and I put traditionally because I think we've expanded indications and it's how we let them function after they get an articulating spacer. But traditionally, those with disrupted extensor mechanisms, poor soft tissue hosts, such as this patient that's at both medial and lateral gastroc flaps and is still draining, as you can see in the middle, and those patients with true massive bone loss in which there's nothing to place articulating spacer, particularly on the femoral side. So this is a video that Kevin had alluded to earlier about cement mixing. So per 40-gram bag of simplex cement, that's important because of the elution properties of cement, typically we'll place 3 grams of vancomycin, 3.6 grams of gentamicin, and 150 milligrams of amphotericin B antifungal if you're concerned. Usually repeat two-stage exchange arthroplasties, known fungal infection. Now you can see this is my assistant here. What she's done is she's went ahead and she's mixed the powder with the liquid. She's made it a liquid format, squirted in a little methylene blue to get a little more fluid in there. And then you could see the vancomycin, gentamicin, and amphotericin B are off to the periphery. And only when there's liquid with both the powder and the cement liquid, and that's made a liquid status, then she's adding in the antibiotics. If you put the antibiotics in with the powder and then you put the liquid in, you will be unable to mix it. So this is quite important. You'll sequentially mix it in, and then you'll be able to get these high dose antibiotics. This is per a single bag of cement. You'll be able to get anywhere from 12 to 15 grams of cement per bag of that, antibiotics per bag of cement, as you can see here. My workflow on articulating spacers to those 2 dowels that Dr. Truesdell showed you, we put one up the femur, one down the tibia. I do that in all articulating and non-articulating spacers. I open up the femoral and tibial canals. I irrigate them. I debride them, and we place those dowels in there. You can see both of them placed, the femur and the tibia. And all it is a cement gun with one batch of cement in which we squirt it in there, take that nozzle off, let it harden, form that little buttress area on the top, put another cement nozzle on there, fill that up, and make your second dowel. And these are very easy to place and very easy to remove. What I'll then do is I'll take another batch of cement, with that antibiotic concoction that I previously showed you. And what I'll typically do is I'll coat the femur and coat the tibia. This is a pretty easy one with minimal bone loss, but this is quite helpful as your bone loss increases, using one extra batch of cement to coat that femur and that tibia to get that high dose antibiotics up against that host bone when fighting that periprosthetic joint infection. And then what I'll do is I'll cap the femur. I'll take my trial femoral component. Traditionally, I use a standard femoral component, but I'll use that trial. I'll cap that, and I'll create interdigitations to cement that on. And my workflow is to use a brand new femoral component to the system I'm likely going to reimplant the patient with. Once I do that and I've capped that, I'll then take that extra cement that I had usually from the femoral side, and I'll cap that tibia. That's helpful for me. You can usually get kind of a gestalt on how much you want to build that up for how much bone loss you have, so you don't have too thick of a polyethylene in the particular system. So I'll cap that tibia, and that usually will take care of the bone loss that we have with it. What I'll then do is I've got static images on the left and then a video of me doing on the right. What I'll then do is take a new PS femoral component in most cases, and I'll place that on there. That's size specific. I'll impact that. And because of antibiotics, there's so much high dose antibiotics in the cement, I don't do anything different. I'll impact it. I won't hold it real tight. I won't intentionally let it be dirty, dry, or clean. I'll just impact it there, hold it in place, and let it solidify on that cap femur. Then what I'll do is I'll take trial polyethylenes and I'll place them in there. I've got that tibia capped. I've got the femoral component cemented on there. And typically it's going to be bigger than usual because you don't have a metal back tibial component in place. So these may be polyethylenes that are somewhere in the range from 15 to 20. And I'll open up, in my hands, I'll open up a TS version or a varus valgus constraint version of it that's accepted in this femur. I'll burr the back of it so it interdigitates, similar to what Kevin showed you on the back of the polyethylene for the hip. Make some interdigitation, leave those little flurries on there, and then I'll cement it in place. You will want to get full tibial exposure so you can get the cement on there, put that tibial component in there. Lots of people like to use an all polyethylene tibial component. I don't. And we could discuss in the discussion section why I don't do that. I'll impact that there. I'll build the cement around it. I'll hold that in place to allow that to solidify. So we're cementing the femur and tibia separate, as we often do in the revision settings. We'll build it up to the articular surface of it. Then I'll reduce the knee, and your usual postoperative radiograph will look like this. There's an AP and immediate post-op and a lateral on the right there with that buildup of cement and that high dose antibiotics. What are the data? Infection eradication, about 90% with articulating spacers. Higher range of motion after reimplantation. There are now 2 randomized clinical trials showing that the big difference between non-articulating and articulating is certainly higher range of motion at most recent follow-up after reimplantation. Lower complication rates and shorter length of stay, only by about half a day, but that's what the 2 randomized clinical trials show. Expanded indications, well, not really. People say you're doing more and more of these articulating spacers. I'd say we're utilizing articulating implants and surgical techniques, but oftentimes those with bigger bone loss, compromised wounds, or extension mechanism disruptions, while we'll cap the femur and the tibia with implants like you saw, we'll keep them immobilized, whether that's a custom brace, a cast typically in our hands, or some sort of immobilizer. So that protects the bone, but it's how you functionally allow them to use that particular spacer. And that includes some patients with prior spacers and extensor mechanism disruptions, some with compromised soft tissues. Again, we'll put those implants in there, but we want to let them articulate it. And some of those that are really limited, that you can't cross that bridge, is really these ones with massive bone loss, such as this patient that had fractured femoral component infection, in which there's no way in any world you can do articulating spacer. We utilize this so-called internal X-fix that we can discuss in the discussion section. So in summary, many of us have migrated more and more towards articulating spacers. My preference is a conventional metal on polyethylene articulation. It's simple and reliable. It's off the shelf in your hospital with whatever implant system you typically like to use. You can deliver high dose local antibiotics, and it preserves knee function and simplifies, for me, the exposure on the way back in. Thank you very much.